So I'd like to share the case of a routine phaco surgery performed for a lady that has had a DALK for advanced keratoconus stage 4 with scarring and previous high drops. She is currently 60 years old, and the DALK has been performed about a year ago by our team. So what you can appreciate is that there are some strange lines in the cornea that are slightly out of focus as we're doing the capsulorhexis. These lines are actually excess decimase that has been retained during the manual DALK procedure. So as you know, during DALK, we always try to keep the patient's decimase intact so as to reduce the steroid burden that we have to administer the patient after the surgery. And having conus, she is also highly myopic. And we're doing this surgery mostly for refractive reasons, although you will soon appreciate that there is also a moderately dense nucleus, so it's not only for refraction purposes. So what else we've changed regarding our phaco surgery is that we've made the phaco wound a bit more posterior than we would have liked to, actually going through conjunctiva. And then we've side cut the conjunctiva with the keratome to prevent ballooning of the conjunctiva that usually occurs if you create your phaco incision too posteriorly. But in this case, we've really wanted not to have our phaco wound engage the graft-host junction, because if that happens, then the chance of intraop double AC formation is higher. And we're performing our routine phaco, and if you've been paying attention, you've noticed that we did a side chop because the nucleus wasn't easily rotating, and the patient has a very deep AC, as is usually the case in keratoconus eyes. And that side chop was a bit cavalier because we were quite confident that we were in the right plane with the chopper, but as will soon be apparent, that chop was a bit too anterior and we actually cut through the anterior rhexis. But that's not proving to be a problem. So we're proceeding with normal phacoemulsification. We're also performing a very low flow phaco, also protecting the endothelium because why wouldn't you in all cases, but especially in a DALK case where you've fought during the transplant surgery to maintain the endothelium, you should also do that during the phaco surgery as well, because if this patient needs a graft, then you're losing all of the benefit that you've had from the DALK. And probably if there's endothelial dysfunction in this case and the patient needs a DMEC, then the DALK was for nothing, and that would be a pity. So now we're moving on to the epinucleus phase, which, if the hydrodissection is done properly and generously, is of no concern. You don't want your main wound to be leaking, but this sometimes happens when immediately after you take the phaco needle out of the eye, and you can appreciate that by the flow of blood from the conj incision, that the blood is flowing out. So that means that there's also some fluid flowing out. But as long as the chamber is reasonably stable, there's no need to hydrosuture the incision. You would hydrosuture the incision if you had chamber instability. And what happens if you hydrosuture these corneas too aggressively is if that edema from the hydrosuture engages the graft-host junction, then there's also, again, an increased chance of double AC formation. This has happened to us a few times during phaco in cases where we had DALK's procedures previously, and it's not the end of the world. It's just very important to notice intraoperatively if that happens, just like with any decimase detachment in any phaco case. About the IOL calculation, this patient required a +6 lens for a -3 outcome. So she would have been quite happy with no lens at all. She would have been emmetropic for distance with no lens, but we don't usually like to do that, especially in high myopia cases where the fellow eye is also myopic. You kind of need to go to -3 so you have some semblance of isometropia after the surgery. And this is a very thin Alcon Clarion +6 lens that it looks so thin when you load it into the injector. And now we're just placing it inside the bag. Some of you may wonder if the folds in DESIMAs are visually significant. Usually they're not, and the patient doesn't really notice them. But anyway, there's nothing to do about it, because what happens with the folds is that they originate from excess DESIMAs, so there's no point in trimming off DESIMAs so as not to have the folds. That's the surgery. Thanks for watching.